from the University of Mississippi Medical Center, along with my co-authors, Dr. Jimmy Ranganwala and Dr. Yusuf Alamada. We would like to present a case of primary angiosarcoma of the bone. The history is a 49-year-old female who presented to the clinic complaining of left thigh pain for several months. She described this as a constant dull pain localized to the left thigh, which had progressively worsened. There were no alleviating factors. The pain was exacerbated with movement and was worse at night, especially when lying down. The patient was walking with the assistance of a cane, but denied any specific neurological deficits. Initial lateral and AP radiographs of the left femur demonstrate an expansile lytic lesion based on the cortex. There is a lack of periosteal reaction, and there is no significant bony sclerosis along the margins of the lesion. There is also no internal matrix. CT without contrast was obtained. The image in the bone window on the left demonstrates the expansile lytic lesion with no bony sclerosis or internal matrix. The image in the soft tissue window on the right demonstrates that the lesion has diffuse intermediate internal density with a break in the thin and expanded posterior cortex. Axial T2 MRI image and sagittal stir demonstrate heterogeneous T2 and stir signal hyperintensity throughout the lesion. There are thin, hypointense internal septations. Axial T1 MRI image demonstrates intermediate to low signal intensity throughout the lesion. Following IV contrast administration, there is diffuse lesional enhancement with areas of non-enhancement that may indicate necrosis. Incisional biopsy was performed. The intermediate magnification image on the left demonstrates a proliferation of spindle to epithelioid cells. There are poorly formed vascular channels and extravasated red blood cells. The higher magnification image on the right demonstrates cytologic atypia with atypical mitoses and intracytoplasmic lumens, as well as extravasated red blood cells. The final diagnosis is primary angiosarcoma of bone. This is an almost purely lytic lesion on radiographs and a lobulated T2 hyperintense enhancing lesion on an MRI. These findings are characteristic of angiosarcoma, but are not at all specific. The top differential diagnosis in this case is an aneurysmal bone cyst. In contrast to an angiosarcoma, an aneurysmal bone cyst would not be a predominantly solid and enhancing lesion. An ABC would typically consist of cystic spaces containing blood fluid levels with a rim of enhancement along the periphery of the cystic spaces. Other differential diagnoses to consider are an osteosarcoma, but there was no osteoid formation or periosteal reaction. Metastasis from highly vascular neoplasm such as renal cell carcinoma could have a similar appearance, but there were no cells on the histopathology images that were indicative of metastasis. An epithelioid hemangioendothelioma is a very rare low-grade tumor that appears very similar to angiosarcoma on both imaging and pathology, and hemangioperiocytoma, which more commonly has large feeding vessels on CT and prominent vascular flow voids on MRI. The take-home messages from this case are that primary angiosarcoma of the bone is an extremely rare malignant vascular neoplasm with a peak incidence in the 3rd to 5th decades of life and a distinct male predominance. It typically presents as an almost purely lytic lesion on radiographs and CT, with a lack of sclerosis along its margins and no internal matrix or significant periosteal reaction. On MRI, the appearance is a lobular or septated T2 hyperintense lesion with low signal intensity on T1 and with a variable amount of enhancement due to necrosis and hemorrhage. And despite being a vascular neoplasm, there is a variable degree of distinct blood vessel formation on both imaging and pathology. Thanks for viewing our case.